Usually, when we talk about a medical diagnosis, there's this expectation of like precision, like engineering.
Right. Yep.
You break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, there it is, broken.
Exactly. There is a sort of binary comfort in that. I mean, we really like our problems to be visible, neatly categorized, and, easy to measure on a chart.
You do, but then you step into the world of trauma and human psychology, and suddenly that x-ray machine is it's useless.
Yeah, completely.
We're looking at a diagnostic landscape that is incredibly murky. And if you're tuning in today, maybe you're trying to understand yourself better or, support a loved one, or maybe you're just curious about how the mind works.
Which is a great reason to be here.
Yeah, absolutely. So today we are taking a deep dive into a document that really clears up that murky water. It's a comprehensive resource called Coping and Healing, a Georgia Guide to PTSD Recovery. And this is put out by Coping and Healing Counseling, or CHC. They are a telehealth practice serving all 159 counties across Georgia.
And, the guide offers just a really fascinating look at the clinical realities of post-traumatic stress disorder.
It really does.
It completely dismantles the narrow stereotypes we usually associate with trauma. And it maps out how modern telehealth is making this highly specialized, evidence-based recovery actually accessible.
Okay, let's unpack this, because before we can even talk about how to treat PTSD, we first have to understand who it actually affects.
Right.
And reading through the source material, that requires throwing out almost everything society tells us about trauma.
100%.
Yeah.
Because society has trained this very specific reflexive image into our minds when we hear the acronym PTSD.
We immediately picture like a combat veteran returning from a war zone.
Exactly. And while veterans absolutely do experience PTSD, and we don't want to diminish that at all, framing the disorder exclusively around combat leaves out a massive, massive portion of the population.
Yeah.
The guide from CHC hits this point right out of the gate. PTSD is not just a combat diagnosis.
Right, because the U.S. lifetime prevalence for PTSD is it's near 6%.
Which is huge.
It is. That's roughly 1 in every 16 people.
Yeah.
When you realize how vast that is, the narrow stereotype completely falls apart.
It really is.
I mean, the guide lists an incredibly wide array of experiences that can trigger this. Car accidents, sexual or physical assault, medical trauma, complications during childbirth.
Childbirth is a profound example, actually.
Yeah.
Because it's something society uniformly frames as a purely joyful event, right?
Mm-hmm.
But it can involve severe medical emergencies that place the mother in a truly life-threatening scenario.
Wow. Yeah, that makes total sense.
The guide also lists sudden loss, community violence, and childhood abuse. And rates are particularly elevated among women, first responders, and survivors of interpersonal violence.
Now, what stands out in the text isn't just the variety of direct physical traumas. It's the assertion that you don't even have to be the direct physical victim to develop the disorder. The guide notes that simply witnessing harm to someone else can be a trigger. But wait, I have to push back on that slightly, or at least try to understand the mechanism.
Sure.
How can someone who just, saw a terrible car accident develop the exact same clinical disorder as the person whose body was actually crushed in the vehicle?
What's fascinating here is the distinction between a physical injury and a psychological one.
Okay.
Because trauma is not defined by what physically impacts your body. It's defined by how your brain processes a profound, overwhelming threat.
Oh, I see.
Right. So when you witness something horrific happening to someone else, your brain's threat detection system, the amygdala, it doesn't have time to logically differentiate between them and me in that split second of terror.
It just registers a massive existential threat to survival.
Precisely. The brain perceives a catastrophic failure of safety. So the psychological overwhelm is identical, meaning the neurological short circuit that leads to PTSD can be identical, regardless of who absorbed the actual physical blow.
Wow. Okay, so because the brain is miscategorizing this threat, the fallout doesn't just stay confined to the memory of the event.
Right, it bleeds into the present.
Exactly. It bleeds into the person's present reality.
Yeah.
And that 6% prevalence we mentioned, that translates into daily life through 4 specific symptom clusters.
And the guide notes, these must last for more than 1 month to meet clinical criteria.
Right. So let's break those down.
Sure. So those 4 symptom clusters are really the pillars of the diagnosis. The first is intrusion symptoms.
Okay.
And this isn't just, remembering a bad event. The past, effectively intrudes on the present through flashbacks, nightmares, and intense physical reactions to reminders.
So it feels like it's happening right now.
Exactly. The brain hasn't filed the trauma away as a past event. It replays it as a current, ongoing threat.
And that relentless intrusion kind of dictates the second cluster, right? Avoidance.
It does.
Because if your brain feels like it's under active attack, your instinct is to control your environment.
Naturally, yeah.
So this means avoiding specific places, avoiding certain people, or even shutting down conversations that might trigger those intrusive memories.
Right, and you can see how that would just shrink someone's entire world
Totally.
until they're living in a very small, heavily guarded box.
And that isolation naturally feeds into the third cluster, right?
Yes, which involves negative changes in mood and cognition. The individual often develops a distorted sense of self-blame, thinking, I could have prevented the event.
Oh, wow.
They might experience persistent fear, anger, emotional numbness, and a profound detachment from other people. It operates like a gray filter descending over their entire reality.
Which leaves the fourth cluster, hyperarousal.
Hmm.
The nervous system is essentially stuck in overdrive.
Yeah.
And this manifests as hypervigilance, an exaggerated startle response, severe sleep disturbances, and irritability.
And the physical toll of that hyperarousal is exhausting. I mean, the body is constantly flooded with stress hormones, waiting for an attack that just isn't coming.
Hearing you describe these four clusters, so that's intrusion, avoidance, negative changes, and hyperarousal, it sounds exactly like a home security system that got tripped during a real break-in.
Oh, that's a great way to put it.
Right. Think about it. The trauma was a real break-in, a true threat. But long after the burglar is gone, the system's wiring is fried.
Yeah.
Hyperarousal is the alarm going off every single time the wind blows a branch against the window. Avoidance is the homeowner refusing to ever enter the kitchen again because that's where the alarm initially went off.
That analogy perfectly illustrates the neurological mechanism we touched on earlier.
Yeah.
Because the threat detection center of the brain is the broken security system.
Yeah.
And it is entirely overriding the logical part of the brain that knows the house is currently safe.
And the constant blaring siren makes it impossible to sleep or, enjoy living in the house, which brings in that negative mood and those intrusive thoughts. The house literally becomes a prison.
The CHC guys makes a vital point that aligns perfectly with your analogy. These reactions, the flashbacks, the jumpiness, the urge to avoid places, they are not a sign of weakness.
That is so important to hear.
It is. Just as a broken security system isn't a moral failing of the house, these symptoms are clinical features of a condition. The brain is doing what it thinks it needs to do to keep you safe. It's just completely misfiring.
Seeing how these four pillars dismantle a person's day-to-day life, the instinct is to immediately start labeling these behaviors when we see them in ourselves or our family.
Right, of course.
Especially since we live in an era where there's a massive temptation to just WebMD ourselves.
Oh, constantly.
And the guide even mentions tools like the PCL5 screening, which is a quick 20-question survey a primary care doctor might hand you on a clipboard to measure symptom severity.
Now, the PCL5 is a highly effective screening tool for identifying someone who might be struggling.
Okay.
But the source material is adamant on this distinction. A screening in a primary care setting is a flag, not a finish line.
Oh, interesting.
The clinical diagnosis must be made by a licensed clinician through a structured assessment.
But wait, if I take the 20-question quiz and I score high for hyperarousal and avoidance, I'd assume that's enough to start calling it PTSD.
If we connect this to the bigger picture, the reason self-diagnosis is heavily discouraged in mental health is the sheer complexity of the human mind.
Okay, that makes sense.
Many psychological conditions share the exact same outward symptoms.
Huh.
So a proper evaluation by a licensed clinician is necessary to distinguish PTSD from a whole host of overlapping conditions that, frankly, a layman simply cannot untangle.
Right. For example, the guide mentions acute stress disorder.
Yes. Acute stress disorder looks nearly identical to PTSD in terms of the intrusion, avoidance, and hyperarousal.
Oh, really?
Yeah, the difference is the timeline. Acute stress disorder occurs in the immediate aftermath of a trauma and lasts from 3 days up to 1 month.
Okay, got it.
If those symptoms persist beyond the 1-month mark, the diagnosis shifts to PTSD.
So the timeline dictates the label. What about complex PTSD? Because I see that thrown around online quite a bit lately.
Complex PTSD, or CPTSD, often stems from prolonged, repeated trauma. So think chronic childhood abuse or long-term domestic violence, rather than a single, isolated event like a car crash.
Oh, I see. So going back to our analogy, if standard PTSD is a broken alarm from a single break-in, complex PTSD sounds like the house was built in an active war zone. The alarm system never even had a baseline setting for safe.
That is an excellent way to conceptualize it, yeah. The treatment approach for a chronic developmental trauma requires different pacing and specialized focus compared to a single incident trauma.
That makes total sense.
And the guide also notes the necessity of ruling out dissociative disorders and panic disorder. Furthermore, a structured clinical assessment identifies co-occurring conditions, which are incredibly common.
Yeah, the guide specifically notes depression and substance use, which makes perfect sense logically.
It does.
If your internal alarm is blaring 24/7 and you
Yeah.
can't sleep, you're likely going to turn to a substance like alcohol, prescription medications, whatever's available, to manually power down the siren.
Exactly. It's a very common attempt at self-medication. But if a primary care doctor only treats the secondary depression or the substance use without identifying the underlying PTSD,
The core issue remains untouched.
exactly. An accurate diagnosis is the only key that unlocks the correct treatment protocol.
And the word protocol is doing a lot of heavy lifting here,
Mhm.
because the tone of this guide from CHC is incredibly optimistic.
It really is.
It doesn't just describe the suffering, it promises that PTSD is highly treatable when matched to evidence-based protocols.
Yeah.
But if standard talk therapy, just sitting on a couch and venting about your week, if that isn't enough to fix a fried neurological alarm system, what actually does the work?
Well, standard talk therapy can provide support, but resolving PTSD requires therapies designed to actively rewire how the brain stores the traumatic memory. The guide highlights 4 empirically supported trauma-focused treatments.
Let's dig into the mechanics of these, because the acronyms can be a bit overwhelming. The first one they list is EMDR.
Right, so EMDR stands for eye movement desensitization and reprocessing.
Okay?
And the mechanism here relies on bilateral stimulation. So often, having the patient track the therapist's hand, moving side to side with their eyes, or using alternating auditory tones.
Wait, while they are thinking about the trauma.
Yes, exactly. The patient brings the distressing memory to mind while engaging in this bilateral stimulation.
That sounds intense.
It is, but the working theory is that this process taxes the working memory just enough that the brain cannot hold on to the intense emotional charge of the trauma.
Oh, wow.
It effectively guides the brain to reprocess the memory, moving it from the active threat detection center to standard long-term memory. You still remember the event, but the visceral bodily panic is stripped away.
Wow. So it files the file in the correct cabinet?
Exactly.
The second treatment on the list is CPT, or cognitive processing therapy. How does that differ?
CPT focuses heavily on the third symptom cluster we discussed, the negative changes in cognition.
The distorted self-blame and all that.
Right. Trauma often shatters a person's core beliefs, leaving them with thoughts like, I am entirely to blame, or the world is completely unsafe.
Yeah.
CPT teaches the patient how to identify those stuck points and systematically challenge and reframe those deeply distorted beliefs using Socratic questioning.
Very structured. Now, the third is PE, prolonged exposure. The name itself sounds a bit intimidating.
It is a challenging but highly effective protocol. Prolonged exposure tackles the avoidance cluster head-on.
Because avoidance teaches the brain that a memory or a place is dangerous.
Exactly. So PE involves safely and gradually approaching those trauma reminders,
Yeah.
both by recounting the memory out loud and by confronting safe but avoided real-world situations.
So if you've been avoiding driving after a severe car accident, the therapist gradually helps you sit in a car, then turn it on, then drive down the block. You're actively teaching your brain through experience that the trigger is no longer a threat.
Right. It utilizes a psychological concept called extinction learning.
Got it. And the fourth therapy.
The fourth is trauma-focused CBT, or cognitive behavioral therapy, which combines elements of cognitive restructuring and exposure techniques, tailored often for younger patients or specific trauma types.
Now, the guide also mentions that alongside these therapies, certain SSRIs, specifically sertraline and paroxetine, are FDA-approved adjuncts.
Yes, medication can play a crucial role. While the therapies do the deep processing work of resetting the alarm, the SSRIs can help lower the overall volume of the siren.
That makes sense.
They stabilize the nervous system enough for the patient to actually engage in the difficult work of EMDR or exposure therapy.
Here's where it gets really interesting, because having these incredible evidence-based treatments mapped out is wonderful in theory,
Yeah.
but theory doesn't heal people. We hear constantly about the bottlenecks in mental health care. severe therapist shortages, wait lists that stretch for 6 months, and out-of-pocket costs that run into the
It was a
thousands.
huge problem.
Right. But what stood out in the CHC guide wasn't just the clinical side, it was the operational model they used to actually deliver this care.
It's a very pragmatic solution to a systemic problem. Coping and healing counseling has structured their practice to dismantle the traditional logistical barriers that keep everyday people from accessing evidence-based protocols.
Because the biggest logistical hurdle is geography, right?
Absolutely.
If you live in a major metropolitan area, you might find a trauma specialist. If you live in a rural county in Georgia, your access to someone certified in EMDR or CPT might be zero within a 2-hour drive.
Right.
But CHC operates a 100% telehealth model. Using secure, IPA-compliant video sessions, they serve all 159 counties in the state.
And telehealth completely neutralizes that geographic barrier.
Yeah.
But it also requires a robust clinical infrastructure. The guide notes they have a diverse, culturally competent team of over 15 licensed therapists.
And they list a whole alphabet soup of credentials, LCSWs, LPCs, LMFTs.
Those credentials indicate the breadth of their expertise.
Okay, break those down for us.
Sure. LCSWs are licensed clinical social workers who are highly trained in looking at the environmental and social systems impacting a patient.
Got it.
LPCs are licensed professional counselors, focusing deeply on therapeutic techniques and individual psychology. And LMFTs are licensed marriage and family therapists who specialize in understanding how trauma impacts relationship dynamics and family units.
Which explains why they offer individual therapy, couples counseling, family therapy, and they even work with teens ages 13 and up.
Exactly. It provides a safety net for the entire family system, since trauma rarely only affects one person in a household.
But the final barrier is always financial.
Oh, always.
Specialized trauma therapy requires consistent, regular sessions. If a patient is paying $200 out of pocket every week, they'll drop out of treatment, regardless of how effective EMDR is.
Right. And the financial details provided in the guide are what really bridge the gap between theoretical healing and real-world application. CHC aligns with major insurance networks to absorb the cost burden.
Yeah, for Medicaid patients, the copay is $0.
Which is incredible.
It removes the financial barrier entirely for vulnerable populations. And for commercial insurance, they are in network with Aetna, Cigna, Blue Cross, Blue Shield, United Healthcare, and Humana. Because they're in network, patient sessions are kept between $10 and $40.
By driving the out-of-pocket costs down to the equivalent of a copay for a standard doctor's visit, they make elite targeted trauma care viable for a family managing a standard household budget.
That's amazing.
And they provide their contact information really clearly for Georgia residents.
Yeah.
It's ghactherapy.com or 404-832-0102.
It is such a logistical problem-solving approach to a massive public health issue.
It really is.
So what does this all mean? We have covered a tremendous amount of ground in this deep dive.
We really did. We started by fundamentally expanding our definition of trauma, recognizing that PTSD is not confined to the battlefield.
Right.
It is the fallout from childbirth complications, medical emergencies, car accidents, and sudden losses.
And we mapped out how a brain trapped in threat detection mode creates those 4 symptom clusters of intrusion, avoidance, negative mood, and hyperarousal. We looked at why a clinical diagnosis is necessary to untangle PTSD from acute stress disorder or complex PTSD, and we explored how protocols like EMDR and prolonged exposure actually rewire that broken alarm system.
And most importantly, we looked at how telehealth models are removing the geographic and financial barriers that have historically kept people from accessing those life-changing treatments.
I want to leave you, our listener, with a final thought to mull over as you go about your week. We established early on that roughly 6% of the U.S. population will experience PTSD in their lifetime.
Yeah, 1 in 16.
1 in every 16 people. Think about the people you interact with daily. The person checking your groceries, the coworker on your video call, the neighbor waving from their driveway. How many of them are silently managing a broken internal alarm system? How many are exhausted from the hypervigilance, from the avoidance, from the invisible weight of an everyday tragedy they're just trying to process?
It's a powerful question.
How might understanding this broad, everyday definition of trauma change the grace and the patience we extend to our colleagues and our neighbors? And perhaps even more importantly, how might it change the grace we extend to ourselves? Thank you for joining us on this deep dive. Keep questioning the assumptions society hands you, keep learning, and remember, no matter how murky the waters get, healing is always possible.